Hi everyone, welcome to components of the hematologic system. Go ahead and get started here. I'm Dr. Shields, and I'd like to go ahead and start talking about components of blood. So keep in mind when we talk about the components of blood, we're talking about three main blood cells, 1, 2, 3. We're talking about red blood cells, we're talking about white blood cells, and we're talking about platelets. Those are the three main types of blood cells. So here we have a person, and blood is about 8% of the total body weight. If we take that blood and we put it in a test tube and we centrifuge the sample out, the red blood cells go to the bottom, and then there's a middle layer called a buffy coat, and inside this little buffy coat are the platelets and the white blood cells. And then at the top is the plasma. About 55% of the total sample is plasma. So about 55% or more than half of your blood is blood plasma. Less than 50%, about 45% is your red blood cell concentration. When we talk about hematocrit is the percentage of red blood cells in the total concentration here. And this is a normal hematocrit. Hematocrits can change based on fluid. If somebody has extra volume or fluid volume overload, their hematocrit could appear low. If they have a fluid volume deficit, we take some of this water out, their hematocrit can appear high because it is a percentage of the total blood. So then this test tube is broken out a little bit more. So we take a look at the plasma. The plasma includes the proteins, the water, and some other solutes. So the proteins, most typically we talk about the albumins. You can see 50% of the proteins are albumin. So if we want to measure proteins in the blood, basically we're measuring the albumins. The next part here is water. So about 90% of your plasma, not 90% of your whole blood, 90% of your plasma is water. So hydration becomes a real issue when we're talking about blood, right? It just a big part of it is water. The other solutes in here are ions, nutrients, waste products, gases, different types of substances as well. This little kind of 1% of your total blood volume, this little white layer right here, includes the platelets and the leukocytes, or the white blood cells, okay? And then this bottom part is basically the red blood cells. They go to the bottom, they fall to the bottom because they're heavy. So we have the red blood cells, the white blood cells, and the platelets. These are the three main blood cells, and then you have the plasma up here. If we break down the white blood cells, it's important to know that there are different types of white blood cells. We have talked about these already, but the different types of blood cells that we can actually measure these on a person's lab value, we can get white blood cells with a differential. And when you get the differential, you can see the numbers of the neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And these are the different types of white blood cells. Keep in mind a few important things here. Number one, the neutrophils, you can see, contain about 65 to 75%. They make up the majority of the white blood cells. They are the most abundant. Remember early on in the chapters, we talked about the neutrophils are the first one to go to the site of injury in regard to our immune system. Lymphocytes are next in abundance. Monocytes, eosinophils, and basophils are just a small amount. When we talk about white blood cells, we're going to talk about these in a little bit more, but one way I remember them as far as the amount of white blood cells, neutrophils being the most, basophils being the least, is this little mnemonic: never let monkeys eat bananas. And I always remember the order of the 5 different types of leukocytes. Okay, let's start by talking about the 3 main blood cells. And we'll start with erythrocytes, which is really the majority of what we're going to talk about, are the erythrocytes, or the red blood cells. And they're the most abundant cells of the blood, and they occupy approximately 48% of the blood volume in men and 42% of the blood volume in women. And this right here are normal hematocrits. Okay, so the volume of blood, like I said. Erythrocytes are formed in the bone marrow, like all blood cells. Red blood cells, white blood cells, platelets are formed in the bone marrow. And red blood cells are about 4.2 to 6.2 million in a millimeter cube circulating in the normal blood. So again, this would be a normal red blood cell amount, 4.2 to about 6.2 million red blood cells in a millimeter cubed. Erythrocytes are primarily responsible for tissue oxygenation and contains hemoglobin. So hemoglobin is a part of the red blood cell, which we'll talk about, and it's responsible for tissue oxygenation and carries gases and electrolytes. And these hemoglobin on the red blood cells regulate gas diffusion through the membrane plasma. So oxygen and carbon dioxide from the lungs, and then deliver it to the tissues, giving the tissues oxygen and bringing back the carbon dioxide. Because it cannot undergo mitotic division, the erythrocyte has a limited lifespan, approximately 120 days. It's an important number to remember. So about 120 days, a red blood cell can live in the blood. As it ages and is removed from the circulation, primarily in the spleen, we'll talk about that a little bit more too. They get older and then they have to come out of the circulation. They come out of the circulation through the spleen. We'll talk about how the spleen does that. And then they're replaced by brand new erythrocytes, and the cycle keeps on going. Red blood cells are as a small disc with two unique properties. You can see it up here. It doesn't have a nucleus right here. It has this biconcave shape. So both sides have a concave shape, which allows much more affinity, not affinity, but abundance of oxygen to attach to it. The capacity to be reversibly deformed. So because it is this shape and there's no nucleus, it can turn itself into little shapes and move itself through different small areas and blood vessels and stuff. The next one are the leukocytes, or the white blood cells, and they defend the body against organisms that cause infection, and we have talked about this already, and remove dead or injured host cells of all kinds. The average adult has about 5,000 to 10,000 leukocytes in millimeter cubed of blood, so a normal white blood cell count right here. Leukocytes are classified according to structure. Basically, how they're structured, they're either a granulocyte or an agranulocyte. So when we talk about those, we're talking about the 5 different white blood cells. And according to their function, they're either a phagocyte or an immunocyte. And this is just a little picture right here. The neutrophils, the eosinophil, and the basophil are phagocytes, and they're under the granulocyte. So their structure is a granulocyte, meaning they have little granules on them. And then the agranulocytes are monocytes and lymphocytes. So they're smooth and they don't have granules on there. The lymphocytes are secrete antibodies, and everything else really they're phagocytes. You don't have to memorize that. Just understand that white blood cells either are granulocytes or agranulocytes, and they have a phagocytosis property, or more of like an immunocyte, like a lymphocyte right here, which secrete antibodies. The third one are platelets, and platelets, or thrombocytes, clotting cells, are essential for blood coagulation and control of bleeding. Platelets can assume different shapes and form an adhesive pseudopodia, which is a long surface extension. So you can kind of see this funky shaped cell right here. And that increases the surface area. Okay, so that makes a lot of surface area for the cell because of all these little extensions right here. And it promotes interconnectedness and adherence to collagen fibers in damaged vascular walls. So when there's damage or an injury, then these attach to it, and these little fingers can interconnect and adhere better to the collagen fibers, allowing or promoting plugging of vascular openings, and that helps control the bleeding. The spleen and the lymph nodes. So these are just pictures from your book, and the spleen is divided into a lot of different compartments, and it's kind of broken down into these red pulp and these white pulp. And the red pulp are rich in red blood cells, and the white pulp is rich in white blood cells, which are the lymphocytes and the T cells right here. So the spleen, we talk about the spleen, it is the largest of the lymph organs. When we talk about the lymph organs and the lymph nodes, the spleen is the largest, and it has many roles. We did talk a little bit about the spleen before, but it initiates the immune response. So it plays a big role in our immune response. So sometimes you may see, or you would know somebody has a problem with their spleen, or they get their spleen removed because they've had a trauma or something. So you can live without one, but it's important to know what it does, because if they don't have a spleen, something else in the body has to take over the role. So they initiate the immune response, and if they don't have a spleen, then they're going to have a problem with some immunities. You know, they're not going to fight pathogens as well as they would with a spleen. Obviously, the liver takes over and some other help, but they destroy red blood cells that are old. We're going to talk about that process. The spleen plays a big role in destroying the red blood cells. It also is a reservoir, so it holds on to blood because it has so many blood vessels going through it. It holds on to a lot of red blood cells, a lot of platelets, and a lot of white blood cells. Then this is the lymph nodes, and the lymphatic system, remember, is connected with the circulatory system. So as the lymph travels through and it filters and pulls out pathogens, it can secrete them into the bloodstream, which can carry it around to the heart and through the kidneys and out through the kidneys and out through the bowel. So they're distributed throughout the body. Remember, heavily located up kind of in the neck and throat area, because a lot of pathogens will enter through our mouth, and they provide filtration. And in the first encounter between an antigen or a pathogen which enters our body, it's their first kind of encounter between that antigen and a lymphocyte. So again, these are just scattered various places throughout the body, and those are the lymph systems. So those are important when we talk about our immune system. So next I want to talk about hematopoiesis, which is the production of blood cells, okay? And this activity takes place, again, in the bone marrow. So all of the blood cells are made or produced in the blood cell. And what we have here is we have stem cells right here. So this stem cell has multi-potential, and then it multiplies or breaks down here into this unipotential, these different stem cells that are now going to become specific. And so in the bone marrow pool here, you can see this is the white blood cell, and it's proliferating and maturing, and now they're changing and they're turning into something, meaning they're differentiating with the help of some growth factors into a various type of a blood cell, this turning into a white blood cell, this turning into a platelet, and this turning into a red blood cell. So when we talk about blood cells, you don't have to memorize this. You can kind of see that the white blood cells, there are half of them are stored and half of them are functional. In platelets, some of them are stored, most of them are functional. And for RBCs, we don't store RBCs. Every RBC that our body has, it's using 100% of them. And so this production of red blood cells is constantly going on. Once somebody is born, and this occurs in the bone marrow, and it just continually goes on. This right here, this picture is just kind of the process of a red blood cell, and these are immature red blood cells or nucleated red blood cells. They start off with the nucleus, and these are little erythroblasts, B-L-A-S-T, so blasts mean babies. So erythroblast would be a baby red blood cell. And they will continue to mature, and they mature and they start becoming a reticulocyte here. And a reticulocyte, I want you to know what a reticulocyte is. Sometimes they're called retics. They're the last immature form, and that's the stage prior to becoming a mature red blood cell. And once they become retics, it takes about 24 to 48 hours for them to mature. And the reason I bring this up is we can actually measure reticulocytes in the blood, which can give us an indication if there's more than 1%, maybe about 1% of our total our total red blood cells are reticulocytes, and the other 99% are mature red blood cells. But if we see a high level of reticulocytes, that gives us an indication that these red blood cells are getting dumped out into the bloodstream from the bone marrow too soon, because this person is becoming low on red blood cells. And so the bone marrow wants to help out, and they dump out these reticulocytes. We can measure this and just keep in mind that reticulocytes are baby red blood cells, and they're helpful for diagnosing, and we'll certainly talk a little bit more about that. So most of the steps of erythropoiesis are under the control of erythropoietin, okay? So this slide is the role of erythropoietin, or the abbreviation is EPO, is what I'll call it. It's just a little easier to say, in the regulation of erythropoiesis. So we're going to talk about the regulation of erythropoiesis. So we start here, number one, right here, okay? So we have a decrease in red blood cells, decrease in hemoglobin synthesis, decreased blood flow, hemorrhage, or an increase in oxygen consumption by the tissues. This all leads to a decrease in the oxygenation in the artery, so arterial oxygenation, and that results in tissues having poor oxygenation, or you know that as hypoxia, right? So this is hypoxia, and that stimulates erythropoietin. Okay, hypoxia, decreased oxygenation in the arterial blood, will stimulate erythropoietin. And how it does it is this low oxygenation stimulates the kidney, and that's important to keep in mind that the kidney plays a role in erythropoietin production. So people who have kidney failure really struggle with making red blood cells, and they're always anemic. Have this anemia of chronic disease because their kidneys can't make erythropoietin. So that low oxygen stimulates that kidney to make erythropoietin, and that's a negative feedback system. And once the oxygenation is normal, then the kidney doesn't have to keep secreting the erythropoietin. When the oxygen level goes down, the kidney is going to secrete the erythropoietin. Then the erythropoietin is carried to the bone marrow, and when it goes to the bone marrow, that results in red blood cell production increase, and so hence we get more red blood cells right here. They're released in the bloodstream and then into the tissues, and then the hypoxia is corrected and oxygenation to the tissues goes up. In patients with anemia secondary to like a chronic renal failure, if you're familiar with these types of patients, you probably have given them the synthetic erythropoietin or EPO, and they can administer it to the patients, and they typically get it like during their dialysis. And with that synthetic erythropoietin, that recombinant erythropoietin that we can give them, they immediately have an increase in their level of red blood cells. So that can be very helpful to them. And that's a population, a patient, a chronic renal failure patient who gets regular injections of erythropoietin. The next slide is hemoglobin synthesis. So the red blood cells form hemoglobin in the bone marrow. Okay, so the red blood cells form hemoglobin. And remember, hemoglobin is the oxygen carrying protein. That's what's important to remember. And if you look at a hemoglobin, just a couple basic things about it, there's two main parts, okay? And that's right here, globins and heme. Hemoglobins, and that's a hemoglobin. So hemoglobin is made up of 4 hemes, 1, 2, 3, 4, and 4 globins or polypeptide chains. 2 of the globins are beta, 2 of the globins are alpha. If you have any kind of knowledge of like an anemia called thalassemia, there's alpha or beta. Basically what happens in somebody with thalassemia, there's a genetic mutation in regard to these globin chains right here, sometimes the beta, sometimes the alpha. but there's 4 globins and 4 hemes, and the heme is on the end of each one of the globins. And the hemoglobin has an affinity to oxygen. Oxygen has this affinity and wants to sit on this hemoglobin and be carried through the body. So another part of this slide right here, this part right here I want to talk about, we need functioning heme and we need functioning globin to have hemoglobin, but also some normal development of red blood cells in synthesis of hemoglobin depend on many nutrients. So there are nutritional requirements for erythropoiesis, and typically these are vitamins, and we're going to talk about the main ones right here. And if they don't have these pieces of nutrition, the patient becomes anemic. So erythropoiesis cannot proceed in the absence of 2 main vitamins. Number 1 being vitamin B12, cobalamin, you may know it as, and it is the main vitamin for nutritional requirements for erythropoiesis. So that's something that's important as a provider when you have patients who are anemic. Vitamin B12 is going to be something that you're going to test for. And it has this other little piece to it we have to keep in mind when we test somebody's levels of B12 in their blood and they're low. We have to think about this intrinsic factor, because the vitamin B12 requires an intrinsic factor for transporting the B12 in the belly, and it transports it and helps it absorb. And if there's a intrinsic factor is missing, this person can eat all the B12 they want, but in the belly, if they don't have intrinsic factor, then they never absorb the B12. So that's important to keep in mind as well, because again, somebody who has a B12 deficiency, we certainly want to give them B12, but if they continue to have the B12 deficiencies, we have to test and make sure they have this intrinsic factor, okay? And we'll learn a little bit more about that when we talk about anemias. So again, if there is a defect in that intrinsic factor, they're going to have decreased B12 absorption, and hence they get pernicious anemia or vitamin B12 deficiency, and that leads to pernicious anemia. The second most important vitamin in the red blood cell production and maturation is folate. And this is a little bit more common of a deficiency that we see in patients than B12, but they're both, I got to tell you, they're both pretty common. A B12 deficiency can take years to develop, but a folate deficiency may only take months to develop. Also, something to remember about folate, I think it's important, especially if you're seeing pregnant women. So it is prescribed to pregnant women pretty early on. Obviously, one reason to prevent anemia, because they are more prone to anemia. They need more red blood cell production. And it also protects them, the embryo, from a neurotubal defect. And so this folate is necessary for the embryonic neurotubal closure. So that is really something that's important. You want to kind of put a star there and put pregnant woman. And remember, this is something we want to give them pretty early on, not just for anemia. They do develop a folate deficiency anemia, so that's part of the prenatal vitamins, but again, for that neurotubal closure. Now, these result in a megaloblastic anemia. We're going to learn about anemias in the next chapter, and we're going to have some anemias that cause a small cell anemia, like a little teeny cell, and some that cause a big cell. And these B12 and folate deficiencies cause megaloblastic or large cell anemias. And I'll elaborate on that coming up. Also, there's normal destruction of erythrocytes to prevent anemia, or after 120 days, I'm sorry. So after 120 days in circulation, the red blood cells are removed from macrophages that primarily occur in the spleen. So that's kind of important to remember about the spleen. So right down here, we have old or abnormal or damaged erythrocytes, and they enter into the spleen. And then the spleen breaks them down into different pieces here. And one of the waste products of a red blood cell breakdown is bilirubin. The bilirubin gets excreted out of the spleen into the bloodstream, and that's free bilirubin. And then the liver takes up this bilirubin and conjugates it. So we have unconjugated bilirubin, which circulates in the blood prior to going into the liver, and conjugated bilirubin, which now the liver turns it into a water-soluble substance, so we can excrete this. And so when this bilirubin gets conjugated in the liver, it gets excreted either into the gut, and then it gets stored in the gallbladder, and then it gets excreted in the stool, or it gets renal excretion and goes into the urine. Okay, so sometimes if somebody has like an overabundance of this bilirubin that gets excreted and goes into the gallbladder, it can contribute to some gallstones. But that's primarily, that could, in a basic sense, how our red blood cells get broken down. So remember, if there is no spleen now, this process can't occur, and the liver pretty much has to do whatever the liver can do to remove the old blood cells. The iron cycle is something important to understand too. So here we kind of have the same picture as above. The aged, abnormal, and damaged erythrocytes go into the spleen, and bilirubin is the waste product. We just talked about this right here. And then the iron is also released. So the hemoglobin breaks down, the bilirubin is a waste product, the iron gets released. The iron does not get excreted, it gets reabsorbed and either gets stored in the spleen to be released into the bone marrow later, or it gets transported and it goes back to the bone marrow to help make red blood cells, and the process continues. So iron is very important for the iron to come out and get reused or get stored. So iron is released from the GI epithelial cells and circulate in the bloodstream associated with its plasma carrier transferrin. So transferrin is important to know, because as a provider, when you start seeing patients and you want to check for iron because of iron deficiency anemia, transferrin becomes an important value to measure. Actually, I'm wrong. It's not the transferrin. It's the ferritin that's important, but you still need to know what the transferrin is. The transferrin is, I always think about as transfer. The word transfer is in the word, and it transports the iron through the blood vessels to the tissues, to the liver, to the spleen. So I'm sorry, I'm getting ahead of myself. The transferrin it transfers. It's a plasma carrier. It helps bring the iron back here to the bone marrow. It's delivered to erythroblasts, little baby red blood cells, those little erythroblasts in the bone marrow, where most of it is incorporated into the hemoglobin. Mature red blood cells circulate for approximately 120 days. It's important to know. After which they are removed by the phagocyte system right here. We talked about that as well. And macrophages, mostly in the spleen, okay, that happens mostly in the spleen, break down ingested erythrocytes and return iron to the bloodstream directly or after storing it. And this is where I got ahead of myself. I apologize. This is an important lab value to know, and I want you to circle it. So it either goes directly back to the bone marrow, or it gets stored as in the liver. And it gets stored as ferritin. And I think of ferritin, and I think if you just look at this word tin, and I think of like a tin can or a tin box. And that's what you store something in. So ferritin is iron stores. And that is a real indicator of somebody's iron level. So we can draw a serum iron, the iron that's circulating in the bloodstream. But what really matters is how much iron is stored, how much storage you have, because we can't eat enough iron every day. to help make our hemoglobin. That's why it's important when we break down our red blood cells, they take this iron and our body reuses it and reuses it and reuses it. So it's important to know, do we have enough stored? Because if it's just continuing to go here, that's never going to be enough. We have to have some stored, and ferritin is stored iron. So if the body iron stores are low, erythropoiesis is going to increase, and vice versa. The body's iron balance is maintained through absorption. A lot of things are actually maintained through secretion, like this bilirubin, but not iron. It's actually maintained through absorption. And we're going to talk a little bit about iron deficiency anemias. If somebody doesn't have enough iron storage, then they have an iron deficiency anemia. And sometimes somebody stores too much and circulates too much iron, and that's called hemochromatosis, too much iron, and we'll talk about both of those coming up too. The next slide talks about mechanisms of hemostasis, and hemostasis is the arrest of bleeding by formation of blood clots at sites of vascular injury. So how does our body stop ourselves from bleeding to death? Okay, so blood clotting is basically what we're talking about. A steady state of blood volume, pressure, and flow are maintained. Three components of homeostasis are vasculature, the endothelial cells, and some endothelial matrix. We'll talk about that in a minute. And so this process here occurs in the vasculature. The second component of homeostasis is platelets, which come into this process. And the third are clotting factors. So these three things have to be working for homeostasis to occur. Okay, so if not, we don't get a steady state of blood volume, pressure, and flow. We get blood clots or we get bleeding. Something is wrong in that area. So let's talk about the process right here. Your book goes into a lot of elaboration on this, and there's just not time for that. So just kind of a basic overall understanding. First thing, we know that there's an injury, a rupture to a blood vessel. We cut ourselves with a knife. A blood vessel is damaged. And the blood vessel around the wound constricts. So that vessel constricts or contracts. That's the first stage. Reduces the blood flow to the damaged area because of the restriction. So not as much blood can get there and start gushing out of the hole. Activated platelets are the first thing now after the vasoconstriction. The platelets are the first thing that come to the site of injury, and they're sticky. And they start sticking to the site of injury, and they make this platelet plug. So they become sticky and clump together to form this platelet plug. Platelets and damaged tissue. Okay, now we have damaged tissue and platelets, and because of that, it releases the clotting factors. Okay, so all of the clotting factors that you just saw in the video, that whole clotting cascade gets activated right now after the platelets get released. And then blood clotting mechanism to form fibrin, which acts like a mesh to stop the bleeding. And so after this clotting cascade occurs, remember, it's one thing I want you to know, the end product of that clotting cascade is fibrin. It's that mesh net. So after the platelet plug, clotting cascade, the end product of the clotting cascade, fibrin clot like a little net, it goes on top of it. And that's how the blood vessel can clot. And then we have the fibrinolytic system, which after a clot is formed, it has to be dissolved. The body has to dissolve it, and that's what this is. So the clot is formed, it retracts, it becomes solid, and then lysis occurs. And lysis is a breakdown of the clot, and it's carried out of the body and away from that vessel by the fibrinolytic system. So fibrinolysis, okay, the breakdown of the blood clot is initiated by the binding of plasminogen. Okay, so we have this clot right here. Plasminogen activator, which is TPA. And it initiates a fibrinolysis or a breaking down of the clot. And then urokinase, which is another plasminogen activator, is a major activator of extravascular. So regardless of what they do, you need to know that activators of this fibrinolytic system are TPA and urokinase. Plasminogen activator, which is TPA, plasminogen activator, which is urokinase, and sometimes abbreviated as UPA. Those are important two things to remember. And those are the major activators with this plasminogen to break that clot down. That plasmin digests, okay, they make this plasmin, this process right here, and that plasmin digests the fibrin into smaller soluble pieces, and those are called fibrin degradation products, or FDPs, something you may be familiar with. So both the TPA and the UPA have been used clinically, you probably recognize the names, to treat diseases associated with blood clots, mostly strokes, MIs, and pulmonary embolism. Okay, that's when we see these drugs used, but these are actually chemicals in our body that work every time we have a clot in our body due to an injury. One thing I want to bring up here when we talk about the FDPs, a major FDP is called, there's different types of them, but one that you're familiar with is called a D-dimer. So a D-dimer is one of the types of FDPs, and you know that we can measure D-dimers. We can draw somebody's blood, and measuring the D-dimer is useful for diagnosing because a D-dimer can increase in cases of a DVT or pulmonary embolism. It's not a diagnostic to tell us that somebody has a DVT or a diagnostic to tell us that somebody has a pulmonary embolism, but what it gives us is information that there is a little bit of extra FDPs in the blood, meaning that extra clots are breaking down. So it is normal to have a small amount of FDPs, but it's not normal to have a huge amount of FDPs. So that's kind of an important piece to remember. And this last piece, section we're going to go through is clinical evaluation of the hematologic system. And the first thing I want to talk about is tests of bone marrow function. So usually bone marrow, it can be aspirated, and we can get a bone marrow aspiration and a bone marrow biopsy. And so it starts with aspirating bone marrow, and generally it's from the sternum or the pelvis using a needle. And the reason they use the sternum or the pelvis is this is where the most active bone marrow is. Active meaning it's bone marrow. There's two different types of bone marrow. One is active and one is not active. And so they want to get the active bone marrow that's producing these red blood cells. In children, it's a little bit different. They can get theirs from the femur and from the vertebrae, and that's where most of their active bone marrow is. The aspirate is examined microscopically to evaluate all blood cells. So to get the biopsy, the aspirate and the biopsy, they stick a needle in that bone. It can be pretty painful, but it's an important test, and it can diagnose any central defects that occur in hematopoiesis. So it can help diagnose anemias, blood cancers, most particularly leukemias. So first we get blood levels, and there's certain blood levels that are abnormal. A bone marrow biopsy might be something that's needed next to diagnose a lymphoma or a leukemia, or maybe like a multiple myeloma or something. And blood tests, this is not something that you need to memorize. Obviously, a blood test is done first, and we have some abnormals. It may warrant a bone marrow biopsy. But the only thing I'm kind of thinking here, what I want you to know, so there's a couple things that you should know from here. So let's just go through a few things, and you can mark some things down, but you definitely don't have to memorize this chart. So you should know what a red blood cell count is, and I think we talked about that enough. You don't have to know norms. If I put a blood value in your exam, I will write if it's high or if it's low. Here's two that we're going to go over in the next chapter, but it's a good thing to sometimes get introduced a couple times to something. And when we get a red blood cell count, we can get an MCV, or a mean corpuscular volume. And the second one is a mean corpuscular hemoglobin. This doesn't have MCV here, but put MCV here. MCV and MCH. Know the difference between them. An MCV volume gives us the information of the size of the red blood cell. So some anemias, like iron deficiency anemia, thalassemia, they have little teeny weeny blood cells. A B12 or folate deficiency, they have big fat blood cells. So we can measure this MCV and see the size of the erythrocyte, and it certainly is a helpful diagnostic to help us determine what type of anemia somebody has. And then the MCV is mean corpuscular hemoglobin. It's the amount of hemoglobin in each of the erythrocyte by weight, and so it gives the hemoglobin its color. And again, sometimes the hemoglobin is very pale. They don't have any globin because they have a thalassemia. They don't have any iron, so they have a iron deficiency anemia. And it can be really pale, but it measures the color, or the hemoglobin, which gives them the color. The MCHC is the same thing as the MCH, but instead of being the amount, it's the concentration of hemoglobin, but these are both the same concept right here. I think you know what a hematocrit is, right? The percentage of given volume of blood that is occupied by the erythrocytes. Remember that very first picture that I showed? That ratio is the hematocrit. Also the reticulocyte count, the number of reticulocytes of blood also expressed in percentage in the total red blood cell. Like I said, it's generally about 1%, maybe 2% is normal, 1 to 2%. And then it can give us an indication if the bone marrow is hyperactive or hypoactive. Is it producing really too much too fast? And so all the little babies are getting spewed out too, or is it just not producing anything? So a reticulocyte count can be helpful in that. This is ferritin. We talked about ferritin, tin, okay? It can be evaluated for depletion of body iron, potential deficiency. So ferritin, that's super important when we're looking for iron stores. That's what I want you to put there. Total iron binding capacity basically shows us the amount of transferrin in the blood. And remember, transferrin is a protein that the liver makes here, that transferrin that transfers or transports the iron. Don't usually do that too much. This is the differential right here. We talked about a white blood cell count and then a little bit of a differential right here. So the neutrophils, lymphocytes, the monocytes, eosinophils, and then the last one that isn't actually here is basophils, and we'll talk a little bit more about those in detail. The last slide here, as far as aging in the hematologic system, there's really not a lot, but they are more prone to an iron deficiency anemia because they absorb less iron, so their iron levels go down. Hemoglobins are lower because they just replenish more slowly. Lymphocytes are lower, causing a decrease in their immunity. And basically what happens as we get older and older, our thymus gland gets smaller and smaller. So by the time we get to be of older age, we don't have a thymus cell, so the T cells just go down to barely having any T cells. Platelet count remains stable, but adhesiveness increases. So it increases their incidence in a thromboembolism in the vein, like a DVT or a pulmonary embolism. Okay, thank you.